Healthcare IT Meets Insight. I'm your host, Jennifer Crawford. In today's episode, we're delighted to be joined by Andrew Tomlinson, Senior Director of Regulatory and International Affairs with AHIMA. That's the American Health Information Management Association. We'll be taking a deep dive into how healthcare IT regulation evolved in 2025, and we'll hear his thoughts on how leaders need to prepare for new requirements in 2026 and beyond. In his current role at AHIMA, Andrew advocates on behalf of AHIMA members on issues related to the intersection of technology and healthcare, both domestically and abroad. Prior to his time at AHIMA, Andrew served as the Director of Federal Affairs at the College of Healthcare Information Management Executives, CHIME, and as a Director of External Affairs at United Health Group. Andrew has worked on health IT policy for over 10 years, including during a 6-year career at the Office of National Coordinator for Health Information Technology that culminated with a posting focused on international health IT issues and stakeholder engagement for the National Coordinator. A graduate of American University in Washington, D.C., Andrew grew up in Metro Detroit and currently resides with his wife and dog in Baltimore. Welcome, Andrew.
Great. Thanks, Jennifer. I'm excited to be here, excited to be able to talk health IT and getting to have a good conversation about what's happening in the regulatory space on those issues right now.
Wonderful. We're so happy to have you. So before we get started, tell us what initially drew you to work in health information management.
Yeah, it's kind of an interesting story. I was not trained in health information management or health IT or really healthcare at all. I actually graduated with a journalism degree, hoping to do sports writing, hoping to talk a little bit about hockey and the different kind of sports that were of interest in the Metro Detroit area, but ended up falling into a contractor role at HHS at the Office of the National Coordinator, which is now the Assistant Secretary for Technology Policy within HHS, and spent a number of years working in different positions there. You mentioned where I culminated in my posting there, and ended up finding that the health IT space was quite interesting for me and was a good intersection of interests I had both in technology, but then the importance of making sure patients have access to their information, especially in a digital space. And through there, ended up at Chime switching sides essentially and becoming a lobbyist working on behalf of chief information officers within health organizations, and then had an opportunity to come to AHIMA. I really love the membership we have in AHIMA, and we have members that range everywhere from clinical medical coders all the way up through chief health information officers or chief privacy officers. And these are people that are often not necessarily seen within healthcare. And it's so rewarding to be able to have an opportunity to help give them access to the policymakers in Washington, make sure their voice gets heard, and ended up really just hardening my passion and understanding that health information is what drives healthcare. And I always say, and I've really started believing it the late teens and really believe it now, that now technology policy is healthcare policy. There's no way to separate the two. And now I'm here with you today and being able to talk a little bit more health information and what's going to be coming in 2026.
Beautiful. Thank you. All right, let's set the stage and recap for 2025. Looking back at the past year, what were the most significant regulatory changes in healthcare IT?
2025 was a busy year. This is my third different transition from president to president within the White House. When I was at HHS, I started under the Obama administration and left under the first Trump administration. I've lobbied under the first Trump administration, the Biden administration, and now under the second Trump administration. And 25 was certainly one of the most unpredictable years when it comes to health information technology. An interesting year, whether or not you fall on whatever side of the spectrum of the political space, you don't get to hear interoperability and health information technology and health information talked about by the president at the White House. And we did get that opportunity this year. So it is exciting to see these issues elevated up to a higher space. And that's what 2025 really focused on. I think the biggest regulatory change from at least the executive branch side was seeing CMS and Amy Gleason, who's leading the US DOJ service, which was the US digital service, really come out with this interoperability framework and the CMS health tech ecosystem, bringing together different players from across healthcare together to try to look at better ways to get patients better, faster access to their information, trying to use new technologies to access that information. They have those two initiatives underneath there. One's called Killing the Clipboard. We axe the facts. In the teens, we're now killing the clipboard, trying to make it so patients don't have to fill out the same forms every time they go to the doctor, have a digital way to do it, and trying to find ways to enable AI. It really is a shift in how HHS is looking at health information and health information technology policy. Is probably the most substantive initiative since the Cures Act was signed at the end of the Obama administration as it relates to health information technology. But on the congressional side, and I have to give credit to my colleague, Kate McFadden, who leads that work for us, there were so many changes in the payment space, whether that's cuts to the Medicaid program or the way that Congress is looking at how exactly care is paid for in the space. Those are going to have downstream effects into who's able to purchase what, implement things, and how they can do it. And so when we think about the totality of 2025, we have the executive branch pushing forward with the new ways of looking at technology to enable better technology-enabled healthcare, while Congress is putting a little bit of a strain on the payment side of things, which could provide challenges to the providers as it relates to accessing some of that technology.
Digging into that a little more, of the 2025 regulations, which would you say had the biggest impact specifically on data interoperability or patient access?
I think that ecosystem that I talked about is the most impactful thing that we've seen last year, outside of the way that, or if when you really think about the way that HHS has managed interoperability and health information policy since the Office of the National Coordinator was created under the first Bush administration, all the way back in like 2007, 2008. It's really been centered in a small agency that's a couple hundred people. And last year, being able to take that and kind of flip it on itself, right? If you think about how health information technology has been implemented in US healthcare, ONC has set the regulations of what's in the technology. CMS has mandated how provided opportunities for providers to be able to use that technology through the Promoting Interoperability program. And so they've kind of worked in tandem. Last year, it was flipped a little bit. And now CMS is really pushing forward the conversation and pushing providers and technology developers to work closely together, whereas ASTP is kind of working on the sidelines, still looking at subtle tweaks to the program overall. So when we think about the technology and the way that it's going to be enabling better interoperability and patient access, instead of looking at ASTP, we're looking a little bit more at that work that Amy Gleason's doing and that Dr. Oz is pushing forward within CMS and that technology framework to see, okay, can we use better AI APIs? Can we create better application programming interfaces for new applications to allow patients to download their access? There's lots of talk about things like portalitis and how do we end that and making it so that every doctor doesn't have a different portal for every patient. And so when we think about in 5 years, what are we going to talk about as sort of an inflection point for interoperability and patient access? I think looking back at that ecosystem and the interoperability framework will signal that shifting point in how we're looking at that space.
Portalitis, I love that.
I wish I could take credit for that, but I cannot.
All right, let's segue then to 2026 predictions. So how do you foresee the CMS health technology ecosystem interoperability framework playing out in 2026?
We got a little bit of a curveball now at the end of 25 because ONC used to be called and now kind of can continue being called the Office of No Christmas. It was rebranded under Mickey Tripathi to be the Assistant Secretary of Technology Policy. That ONC title, that Office of No Christmas, comes from the beginning of the ACA and the American Recovery and Reinvestment Act and the High Tech Act, and they had to do lots of grant making at Christmas time. So everybody had to work over Christmas. Well, it's back. They have a new rule, the HTI 5, the Health Technology and Interoperability 5 rule that came out at the end of the year. And so now we've got these two things working against each other or in tandem at the same time, I guess, really within CMS and within ASTP, looking at changing the way that both EHRs and the certified health IT products are designed and certified, and how exactly patients and providers are engaging with the actual health system itself. So when we think into 26, how are we going to see both the interoperability framework implemented? We're going to see the first deadlines for things that pledgees underneath the framework itself have to begin delivering on in the March, April timeframe, but we're probably also going to start seeing rumblings about when we're going to see the finalization of this HTI 5 rule this year, which is going to significantly change the EHRs themselves. There are 60 criterion within the certification program that electronic health records have to certify to for providers to be eligible for promoting interoperability points underneath the Medicare program. And 54 of those have either been removed or revised. So as the EHRs change and the framework and the way that the information is flowing changes, we're going to really see in 26 what does a streamlined health information ecosystem look like when it's easier for the data to potentially leave the EHR and more readily available to the patients. We'll probably start seeing maybe some fruits of that labor towards the end of the summer, maybe the fall timeframe.
Are there updates around interoperability standards or API requirements that we should expect?
The biggest change in that HTI 5 rule from a standards perspective, they've signaled within it some API changes. They really want to try to enable the certification program. They talk about it being creating a new floor, readying itself for the new fast healthcare interoperability resource or FHIR API landscape, getting ready for that FHIR API access to move from just sort of a pull space to maybe a push-pull or an ingest and send for the data itself. But aside from just the API pieces of things, the United States Core Data for Interoperability, or USCDI, gets released generally every year. It's a set of standards. It's things as basic as how are you capturing name. It can be as complex as things like how are you capturing blood pressure, heart rate, diagnoses, things like that. I think we're up to 6 right now, but only up to USCDI 3 has been implemented. HTI 5 rule is moving from 3 to 3.1, changing certain fields in alignment with some of the executive orders outside of the White House. And part of the previously HTI 2 final or proposed rule that had USCDI 4 mandated in it, they've pulled that back. So in terms of what major changes in the standards in which data is captured, we'll maybe see something towards the end of this year, maybe beginning of next year, for changing up those standards dramatically. But from the API perspective, with the changes in the certification program, I would really expect to see us, at least by the end of this year, start to hear what the vision for the future is and what a new API landscape might look like.
And how might this affect changes to privacy and security for EHR vendors and health systems?
There's definitely some privacy and security changes that we'll see through there. Part of the changes in the HTI 5 proposed rule is around privacy and security, changing some of the requirements underneath how electronic health records certify to some of the privacy and security requirements in there. But I actually don't think these two areas that I've talked about, the ecosystem and HTI 5, is where we're going to see the biggest changes to privacy and security. There are 2 times a year in which we get what's called from the White House out of OMB, we end up getting the regulatory agenda. We get a fall agenda and a spring agenda. The fall agenda comes out in the spring agenda comes out in the fall. It's very confusing in the way they do that, but they're projecting what they expect to have happen over the next 6-month period generally. In the spring agenda that we got in the fall, they indicated that the HIPAA privacy and the HIPAA security proposed rules are expected to be finalized in May. And so that would shift a major change in the way that those covered entities underneath the HIPAA's privacy and security rules would have to meet different requirements in order to maintain compliance. The privacy rule was proposed at the end of the last Trump administration in 2020, with the comment period closing in 2021. And similarly, the security rule changes were at the end of the Biden-Harris administration, with the comment period closing at the beginning of the new Trump administration. So those 2 areas, if they do hit the May timeframe, would be the biggest changes, I think, to the privacy and security landscape.
And do any of these regulatory changes affect patient data rights and access?
In terms of how it's going to change patient data rights or access, it's not necessarily going to change as much about how patients maybe the rights to the patient's data, right? We know that patients have a right of access underneath HIPAA. That's not going to change. That's not going to go away. But the way they may get access to that information may change, or the way they may be notified about how some of their rights underneath HIPAA are. So for instance, underneath the privacy rule, there were major changes that were proposed when Roger Severino was leading the Office for Civil Rights, which governs the HIPAA rules. And a lot of it was based around trying to remove paper in the offices. They talked about it would be one of the major savers of paper in healthcare, was changing the way that a patient may get their notice of privacy practices. They don't have to get it every time, just has to be available to them in the room itself where they're going to either check in or for their provider visit itself. That's one major change when you think about provider access. So it's not, or patient access. It's not changing the way that patients are accessing, just how they learn about some of that access. Similarly, from the security side, it's not necessarily about patients, more about how providers are securing that information. So whether or not it's requiring a different kind of two-factor authentication or the way that networks themselves are set up for moving that information, those are the major changes that we're going to see. So patients probably aren't going to see it, but it is going to keep patient data safer overall long term.
All right, let's kind of shake things up a little bit and do a rapid fire round mid-pod. Okay, we're going to use this rapid fire to dig into some technical and operational implications. Are you ready?
Sure.
Okay. How should IT teams prioritize their roadmaps to be ready for these 2026 changes?
I think every year you're supposed to be kind of looking at your IT stack in general. One thing that I think IT teams should really make sure they're paying attention to are two different areas that both relate kind of the same topic. They've indicated that information blocking is going to be heavily enforced. IT teams need to make sure that those teams that they may have spun up when the rules originally were finalized need to be back together talking about how best to make sure that data is moving and that they're meeting the information blocking requirements from there. But that same time, they need to be making sure that while they're having those conversations, they also have conversations with their developers and vendors to make sure they understand what they're working on and make sure that they're communicating their needs. They're going to need to advocate for their needs with their vendors as their vendors are also looking through the new requirements they have. That's going to be the biggest challenge, is maintaining attention on what you may need as a provider in these spaces.
So what new technology investments or upgrades might be required?
Where to begin at this point on some of the new things that may be required from there. The biggest requirement, I think the biggest change is going to be on the API side. They need to be ready to make sure that they can either have their trusted exchange framework and common agreement or TEFCA onboarding ready to go, making, if that's something they want to do, make sure they're ready to go to do that, because they can enable that better patient access, which is within many of the different initiatives I've talked about already. So they can either do that or make sure that they are prepared to both talk to patients and understand how exactly data is going to move into a third-party application.
All right, speaking of data movement, how might these regulations influence data governance, mapping, and standardization?
More access creates more challenges in understanding where the data is, when it is, and how it got there. The biggest change that we're going to see is that the information blocking requirements in general have not required organizations to ingest data. They have to receive it, but they don't have to put it into the electronic health record itself. It's very much a send focus. You have to be able to send information out, and you need to be receive it, but you don't have to incorporate it into the record itself. We're going to see those conversations changing. There's going to be more patient-generated health data that's going to be discussed. There are rumors of a rule coming in the year ahead that's going to relate to more patient-generated data. Dr. Oz and the secretary has talked about wanting to have everybody having a wearable. And so when you think about data governance, organizations are going to need to get better at understanding where their data is coming from, how do they determine if they can trust it, and making sure that they're able to track it as it moves through their facility, especially when it comes to sensitive data that may have different disclosure requirements attached to it.
And how might that impact health information exchange strategies?
More data with more people having access to it means more people that you're talking to. And the TEFCA, the Trusted Exchange Framework and Common Agreement, we at AHIMA are supporters of that. That's a great way for you to have new access to different exchange modalities, talking to new people. You can use your Qualified Health Information Network or QHIN that you'll use for your TEFCA onboarding. You can use them to help with that conversation as it relates to health information exchange. There are a number of great organizations nationwide that also help manage health information exchange, but a lot of it is going to be about making sure that the partners that you're exchanging with both have the same set of expectations when it comes to what are you sending and what are you receiving and how you're doing it.
So more people, more data, more data moving around. How might cybersecurity and risk management be impacted here from a regulatory scrutiny perspective?
It's no secret, and this started in 2020. I got to learn a lot about this firsthand at Chime. We had a cybersecurity focus there, and we certainly care about it here on the AHIMA side. Healthcare data has never been more valuable and never been more at risk. Healthcare organizations are targeted almost more than any other organization nationwide as it relates to trying to get access to data, especially from a ransomware space. Although, despite a more complex data environment, really the number one way that organizations are compromised still is the same old ways that we've been compromised for years. It's phishing attacks, it's links, it's people that are having social engineering, it's losing your passwords, unsafe passwords. And so when we think about what a new cyber environment will look like, it's very much going to be more about continuing the education, staying vigilant on what we have done and know works well over time at keeping the data secure and keeping those organizations walled off. The security rule I talked about does discuss things like segmenting networks to try to keep different technologies apart from each other, and that will help on certain ways if there is compromise. But it really is about trusting your tried and true methods of education and protection for simple things like usernames and passwords and link clicking.
Well done, Andrew. You didn't miss a beat.
Yeah, thank you.
I'm going to give you a break and do a quick check-in with our audience right now. Okay, so for those of you in our audience, how are you doing? We'd love to hear your thoughts on these regulations and how you're planning your roadmaps for adherence. Please do leave your comments and the feedback, or let us know directly by emailing us at podcastfeedback@accesscorp.com. All right, Andrew, you ready?
I am ready. Always ready.
All right. So let's move on to talk about broader impacts beyond IT. How might these 2026 regulations affect clinical workflows? And what does this mean for the patient experience and how we all pay for care?
We haven't gotten to talk about one of my favorite. I don't know if it's my favorite or the thing that I have to think the most about in the last 2 years, and that is the electronic prior authorization space. I'll start with the payment. We know that there are rules that are in place. They're not necessarily congruent. I promise you, and I can tell you from the inside, that agencies do talk to each other. They do work together on certain things. I know it doesn't seem like they may do that. Nothing seems that way more than electronic prior authorization, as CMS has implementation guides for new requirements and new standards to make it easier to do electronic prior authorization that are recommended. And ASTP has the same implementation guides that are required. I promise they do talk to each other. I've talked with both of the leaders in the room at the same time about these issues. But electronic prior authorization is coming, and it is coming at the end of this year, beginning of next year. It's going to change the way that care is paid for, not in that it's going to change how the conversation happens in terms of the nitty-gritty with a payer and a provider, but the modality in which that conversation is happening will change. Providers may have the ability, hopefully, ideally, to see whether or not something will require a prior authorization in the room with the patient. I sit on calls every week listening about how this works and how they're going to look at implementing it. And I know for myself as a patient that I've had doctors that'll say, well, this will probably require a prior authorization, so wait 3 weeks to call and schedule it. That's not necessarily what the future is going to look like. The provider will hopefully be able to tell you right there in the room. So when we think about how care is paid for just from the way that the transaction happens, that'll be one of the major changes. When we think about provider workflows, though, AI is the big thing that's been talked about. I haven't really talked about it much here because there's not a lot of regulation about it. But AI is coming. One of the 26 rules does take out the decision support intervention criteria that was in the certification program as it relates to providing transparency to understanding what creates an AI decision. But the workflows themselves of how AI may fit into some of the clinician decision support tools that are available to providers, that's going to change over time.
Might this impact smaller practices versus larger health systems?
That's always the conversation question. And I think we think about it very front of our mind at AHIMA because, if we think about where HI professionals primarily sit, large health systems are going to have a lot of health information professionals. There is a complex electronic prior authorization or just pure prior authorization environment I've talked about, but also privacy and security, release of information. But for a solo practice provider, their health information professional may be the doctor. He's also probably their payroll accountant, their cybersecurity expert, their IT guy, their CTO. And so when you think about more complex tools or the way that those tools are paid for, it's hard not to think about a little bit about the haves and have-nots. It's going to be easier for a large multi-practice group to purchase more advanced tools to implement them. They have more money. They also have more tech stack overhead, the ability to put it into place, whereas a single practice provider may not. And so there is some focus in the administration. We just saw the announcement and release of funds related to rural healthcare transformation. That might be able to help augment some of that. But solving that problem of how do you make sure that patients have the same access to the same technology is one that we've been asking and searching for an answer to that problem for years. And I don't know if we quite have it yet on how do we sort of flatten that landscape down. It's not really an answer to the question that you asked, but it's still an ongoing conversation, I think, that is very apparent.
This is so much, and there's so much unfolding, and you're clearly so well informed, and thank you for sharing all of this knowledge with us. But I can't help but wonder how, considering the volume of changes and the complexity, how do organizations plan for costs? How do they budget for this?
In terms of how an organization may budget for it, it's not completely my area of expertise to be able to help give direct access to that, but to help them understand where they can go and get answers on how to prioritize. I think work with your larger associations or groups like Access or AHIMA or the American Medical Association. I know we work close with them, and the Hospital Association, and anything with basically an A at the end of it or at the beginning of it, we generally work with. Those groups can help you understand what's coming and prioritize that moving forward. I think the other thing is, and I've talked about it before, because things are moving so quickly, a lot of it is going to be about coordinating the time and what's the first requirement that you have versus what's the one that's coming a little bit further. You have to comply and follow all the laws that are in place at the time, but some of those laws have time horizons as it relates to, okay, it's taken effect, but maybe there's a little bit of enforcement discretion. A great example of that is electronic prescribing. It's there, but it's maybe you don't have to meet as high of a threshold as you will in the future. And so when you think about budgeting, start with what's the easiest things to work for, and then also look at what also are the most readily apparent compliance deadlines, and then really leverage the space. People are willing to help groups understand what's most important today versus what's going to be most important maybe in 6 months.
Let's talk about, since you offered up the support here, the role of these professional organizations like AHIMA and HIMPROS. So what role is AHIMA playing in shaping or responding to these upcoming regulations? And can you share some examples of recent work that's helping members?
Yeah, we're really blessed at AHIMA. We're really lucky. We have a great team. Lauren Ripplinger is our chief impact or our chief advocacy and impact officer. Lauren will kill me if she listens to this because I'm always tripping up, and I finally fixed it a year ago and now it's back. She's our chief advocacy and impact officer. She's amazing. She leads a team. We have myself and Tara O'Donnell on our regulatory side. Kate McFadgen and Katerina DeBarros are on our legislative side. And then we have Sue Bowman, who's probably one of the preeminent or the preeminent coding expert in the world that helps lead the coding policy work. All of us together as a team work to both diagnose what's happening in the White House or in the agencies versus what's happening in each chamber of Congress. And then Sue is working to help us understand, okay, what are the medical codes? What are the challenges that they're having maybe at the WHO level that's coming down that we need to get ready for? We work together to understand what is going to be an issue today that you're going to have to implement maybe in 5 years. We have a piece of legislation that is part of our work. We lead with several other organizations, the Patient ID Now Coalition. We have a piece of law that's a piece of a bill that we're trying to move through Congress right now called the Match It Act, about trying to enable better patient matching. That's something that if we do get passed, will be something that Kate's working on today, that I may be working on in 2 years, that then might be actually implemented in 7 years. And so those are one of the ways that we try to help our members understand what's coming. We also listen to what their problems are and then take those back to the regulators to help them say, okay, there are 20 people working on prior authorization. Those 20 people could be 5, and those 15 people could be better positioned within organizations to help solve more complex problems when it relates to health information. How do we make sure that those issues are either brought to Congress, because there needs to be a congressional fix to it, or brought to the agencies so that they can work to be able to change the regulations to be able to maybe alleviate some burden there. There are 2 other initiatives that I do want to touch on that we work on. We do lead the Health IT End Users Alliance. That is a group of organizations that try to bring the end user experience forward, recognizing that primarily in the technology development and policymaking side, end users are often brought in at the end. So how do we work to make the end user's voice louder? And those include providers, and it can include anything from a health information professional to a doctor to a nurse, to even sometimes when you think about end users of technology, the patients themselves. Another initiative we do have is we do co-sponsor with the Sequoia Project, the Data Usability Taking Root movement. One thing that we do here from our membership and from others, we can get data, but it's not usable. We can't implement it somewhere. It's not transferable easily. It's a massive note that doesn't really go anywhere. There's not a standard to it. And so we co-sponsor that work to try to find ways to make data more usable, to find it in more spaces, to make it easily transportable. And so those are just some of the ways that we work as an association to advocate for our members. But really, when we work at advocacy, we are trying to make healthcare better overall, not just for the health information professional or within AHIMA. We are trying to bring solutions that makes healthcare something that can function better with less stress placed on the different entities that are involved in that process.
Noble pursuit. Sounds like you have your work cut out for you.
It's always a busy day. We always have something interesting that's happening.
For sure. Sounds like it. Now, what would be, if you could boil it down to your number one piece of advice that you would give healthcare CIO or CTO preparing for 2026 regulations?
I think the number one piece of advice I can give is try to tune out some of the noise. You're hearing, I've talked myself about a ton of different things that are happening. We've got a framework, and we've got new rules at HTI 5 and privacy and security. There is a lot of things that are happening in Washington, but the proposed rules that I'm looking at today sometimes have effective dates that are in 2027. The one thing I would say is work on electronic prior authorization. I know I touched on that earlier. Be prepared for that. That is going to be probably the single biggest change we'll see in just how payment functions from a actual on the ground technology side. But my biggest piece of advice would be to try to tune out the noise and focus on what's actually in front of you today, and always make sure that you have that lens of both patient access and making patients more empowered with their data, but also with cybersecurity, and make sure that when you're thinking about what might be a new great opportunity, always try to make sure you have voices in the room with you that are able to try to push back and try to poke holes in that. Because we saw with the Change Healthcare attack just a few years ago that as healthcare has become more reliant on sort of sole source solutions to things like electronic prescribing, one attack can cripple the healthcare system. And so make sure that you are thinking with that kind of lens as you're looking at new ways to bring new technology to your organization, and make sure that you have backup options to do things while also looking at what are your new regulatory requirements or compliance requirements, or just new technologies available to you.
Speaking of attacks, what should these teams start doing today to build resilience for future requirements?
Yeah, I would say tabletop it out. I think in terms of whether you're talking about a cyber incident, and certainly play it out, tabletop it, make sure that you are going through and regularly understanding how to respond to it. But from a regulatory perspective on new compliance requirements, let's just use information blocking. It's been a long 5 years. It's hard to believe that in March of 2020, I was both reading a new telehealth policy that rapidly enabled telehealth underneath the pandemic, while also reading information blocking final rule requirements. Just make sure that you and your teams talk regularly and that the training is there. There are training solutions that are at low or no cost. So that way, everybody from those that are picking up the phone to answer questions from patients or other providers know what is responsible from you as an organization's perspective, to those that are actively, sort of in the trenches working on maybe either the IT itself or in direct patient care, have the same level of knowledge, or at least know where to find those answers. Because there is no out clause in a lot of these requirements or compliance tasks to say, well, that was a person that's not really, they're not in the HIM department, or that's not a doctor, or that's not an IT person. That's not how the government looks at those kinds of things. You as an entity are responsible. So just work with everybody that you have available to you.
Can you dispel for us any common misconceptions about regulatory readiness?
I mean, I think the common misconception I'd love to put out is everyone's like, wow, that sounds really boring. I'm like, no, it's actually really great. It does sound really boring for hundreds and hundreds of pages, but as someone trained in writing, I was like, I remember I interviewed for a job and they're like, you mean the congressional job, right? I was like, no, I want the regulatory one. But aside from that, I think the biggest misconception, one of them is, again, I mean, information blocking is such a big piece of it, but work with the government. I mean, the agencies themselves are there to help you. The information blocking itself for providers is defined as those that knowingly know that what you're doing is an attempt to block the transmission of information. So don't be afraid to reach out. Agencies love to talk to those on the ground, especially ones that they are, regulating sounds really scary, but it's really not. They want to help you comply. So use the tools that you have within the taxpayer-funded institutions that are putting these rules and requirements on you, because often they're more than willing to help you. They might not be able to answer a specific question, but they can at least point you in the direction of how to find the answer to it and the regulation itself, or give you the guidelines of, well, I can't give you a specific answer, but we know that it's followed within these requirements and this is what's required of you.
Thank you. Thank you. All right. Just to keep you a little bit longer, this has been excellent.
Sure.
You shared a lot of great details and information with us, and we want to wrap up with a little more of a big picture perspective. How do you see the relationship between policy, technology, and patient care evolving?
Healthcare is only going to get more digitized. This is just my opinion. This is an AHIMA's opinion. I think, the AI revolution that we've talked about is not as close as you may hear on the floor of HIMSS in Vegas in March, or at another large conference like Vive or Health or any of the other ones. What I do see evolving in the way that technology is enabling care is patients are going to know more when they're walking into the room with the provider. Sometimes that's good. Sometimes that's bad. I even myself, and my mom calls and she's getting a test and she's like, well, what does this mean? And, we're Googling together to try to figure out what the answers are. So the intersection with regulatory policy, which is really right now, especially under this administration, very much focused on potentially maybe not the traditional HIPAA covered space of third-party applications or third-party access for patients to aggregate their data or better understand it, is going to change the way that a doctor and a patient within a provider organization may talk, especially with chronic or complex cases. Doctors are going to be able to say and understand, look, you're the patient at this point, probably know more about this than I do, because I'm seeing a wide range of patients and you have a very specific case. And there are technology tools that can help enable that to be a more fulfilling interaction. There are better ways for doctors to have access to more data when they need it, where they need it, at their fingertips. And so when we think about what 2030 might look like, I'm not sure it's going to be the AI doctor that, some may lead you to believe or some may be worried is coming. I think what we're going to see is doctors that are more empowered to find answers on things they're maybe not trained specifically in faster, be able to refer patients over to specialists faster, understanding how much that's going to cost faster, and patients are going to know what they're doing more, opposed to just feeling like they're being shuffled from person to person saying, well, I still don't feel great. Why exactly is this happening? And so that's what I think 2030 is going to do. That's what I think this regulatory space is setting up for, is just a space where more data can provide more insights quicker. So that way there maybe isn't as many days of lag and waiting as we currently see it now.
Beyond the AI doctor, are there any other future trends the industry should watch? And to tack onto that, what do you think should be the industry priority over the next 5 years?
I'll start with the last one, the industry priority. I think no matter what, right now, we still need to work better at creating a more interoperable space. We've gotten great at having interoperable data exchange, but we still are reliant on sole source providers in a lot of different technology spaces. It's also no secret that having more interoperable technologies also generally creates a space of more innovation. Organizations have to compete more on what exactly they're offering, whether that's a provider or a technology company. And so being more interoperable makes the system be more agile. And so we can move to new technologies faster, but also we can have the technologies challenge each other to have the best outcomes. When we think about the other conversations about what should be the priority moving forward and where exactly we think we're going, it's more, the more we can put the patient at the center of the way things are functioning right now, whether or not that's a payment conversation, whether or not that's a direct care conversation, the more that we can prioritize the patient to make sure that the patient feels empowered means that it'll make it a lot easier for everyone involved. Payers will be able to have better, more applied conversations with patients to be able to say, well, have we thought about these different lifestyle trends, or have you looked at this, or how exactly do you think is the best way for you to get care? And providers similarly will be able to move through some of the morass that they have to go through now, whether it's all the forms that have to be signed, the 30 times I have to tell someone that I don't smoke, or my favorite, which is you don't smoke. Okay, how often do you smoke? Well, I just told you I don't smoke, so why exactly would you tell me if I ask me if I want to quit? Moving through some of that, I think, will be the priority. But at the same time, like, we've just got to continue with this, with the doing the things better that we're already doing now, while making sure that everyone feels as informed as possible.
Andrew, this has been a pleasure. Thank you so much for joining us. Tell us where listeners can find more information or engage with AHIMA.
Yeah, thank you for having me. I always love talking about these things. It was great to get to meet you and have a chance to talk about this to you and your listeners. If you want to learn more about AHIMA, you can go to ahima.org. It's ahima.org. Or you can email us at advocacy@ahima.org. We have our own podcast. It's the High Five Policy Podcast. We tackle conversations that are focused generally on 5 questions with policymakers or experts. It comes out once a month, and you can get that on generally everywhere that you can get your podcasts: YouTube, Apple, Spotify. We'd love to have you come and listen, and then that way you can keep track of a lot of these trends that I talked about today.
Wonderful. Thank you so much. That's a wrap for this episode of Access Matters. A huge thank you to our guest, Andrew Tomlinson, for joining us today. It was very enlightening. To our listeners, if you liked today's conversation, it really means a lot if you give us a thumbs up, subscribe, or leave us a review. And we'd also love to know what topics you'd like to hear more about. So please email your suggestions to podcastfeedback@accesscorp.com. Access Matters is produced by Mike Faber and executive produced by Megan McCord. Until next time, I'm your host, Jennifer Crawford with Access Matters.